So I'm John Tobey, I'm a physiatrist in Boulder, I'm at Spine West. We're going to be talking about return to play after cervical spine injury. First I'd like to thank Boulder Neurosurgical and Spine Associates and Dr. Vicencio for asking me to speak. I'm honored to be here. I'd preemptively like to thank you guys for putting up with me for the next half hour. And thanks to Sarah and Sagita and all the rest of the folks who've helped put on such a great symposium. The obligatory disclosure slide, I have none, other than I think I was in this same spot last year where I was caught napping during the post-lunch lecture, so I'm pretty sure that's why I'm talking today. So from my standpoint, feel free to catch some Z's, get a little sleep, but buyer beware, you might be up here next year. My objectives are, we're going to review the cervical spine injuries in sports. We're going to talk about some clinical case presentations, diagnosis, evaluation, return to play criteria on the following of the muscular sprains and strains, burners and stingers, spiritacular spine, fractures, stenosis, post-operative cases, and then the spinal cord issues regarding transient quadriparesis and quadriplegia, as well as spinal cord injuries. So we'll start with the muscular ligamentous injuries. Most of what we'll be talking about today is contact sports. Now, track and field is not a contact sport, but apparently you can hurt yourself with any injury, any sport. So the sprain strain is the most common neck injury. There's no neurologic abnormality, typically no bony injury. Usually, and I say usually, has normal x-rays, normal lordosis, no instability with flexion or extension. However, we've all seen those sprains and strains with the loss of lordosis, the straightening of the neck, possibly some mild instability, and that's really where you run into some problems here, is basically that when you've lost that lordosis, particularly in contact sports, you're putting your neck at a very vulnerable situation when you have that straightening of the spine, particularly if you have any type of instability. So what we're going to talk about a lot is some of the return to play criteria. We'll go over some of the more specifics at the end, but there's several different criteria guidelines out there. The most recent was Dr. Robert Cantu, came out in 2013. The guidelines, which I'll be referencing a fair bit today. That's the same Dr. Cantu of the concussion guidelines and concussion management issues. He also has some guidelines out there from for the cervical spine. We're talking about return to play predominantly with contact sports. Realize that these are expert opinions. There's not a lot of data out there as far as what to support what we're proposing. So they are guidelines. There is a fair bit of controversy with some of these. Some of the prior guidelines that were out there, along the same lines. There's not been a whole lot of change, but towards the end we'll touch on some rather controversial topics. So return to play after sprain or strain. We got asymptomatic, full range of motion, normal neurologic examination. You're going to see this one time and time again. This is the trifecta here today. So if you can memorize this slide, there you go. Go to sleep, go home, whatever you want to do. That's basically my talk in a nutshell. Is everybody needs to be asymptomatic, have full range of motion, normal neurological examination. I think that the asymptomatic one is really the most tricky here. In contact sports, you're dealing with athletes, sports of any time obviously, you're dealing with athletes. Athletes lie. They'll do anything they can to get back on the field. But you got to realize that the organ system that we're talking here with the cervical spine is that it's a vulnerable position. So it's not like we're talking about a mild shoulder separation that you can provide some extra padding, you can play through pain, you can play through the injury. Because with the cervical spine, the risks are higher. It's more vulnerable. The consequences are more dire should you really get injured. So with the next thing here, we'll talk about burners and stingers. Like Dr. Vicencio was mentioning before, this is a common injury, usually with tackling or with this guy here, stealing home. Presents with burning pain radiating down the arm. It's usually brief, self-limited. and oftentimes has a history of a prior issue with this. Some athletes, prior history of many burners. The key here with the burners and stingers is to realize that it's unilateral. It's one arm. So you got a bilateral stinger, that's a spinal cord injury until proven otherwise. It's usually transient, but it's just one arm. So the football player coming running off the field with burning hand syndrome, think spinal cord. There is some debate whether this is a cervical root injury of C5 or C6 or an upper trunk brachial plexus injury. Doesn't matter a whole lot as far as the rehabilitation and the treatment. The electrodiagnostic or the EMG studies out there tend to favor that there's more often injured is the nerve root, C5 or 6, but either or both can occur. So these guys are typically unilateral arm, radiating down the hand, numbness, tingling, typically in a C5-6 distribution. So you got your 6 shooter here for your C6 nerve root on the thumb and the index finger, possibly some proximal weakness of the deltoid and the biceps. The mechanism can be multiple: traction, direct blow, compression. Not one in particular implicates a root injury versus a brachial plexus injury, although the direct blow typically will involve more the brachial plexus. Speaking of the brachial plexus, got to throw in the obligatory anatomy slide here. I would be remiss as a physiatrist not to show you the brachial plexus. I mean, we love this stuff. We draw it all the time. We're totally geeked out with brachial plexus. So, we have one of those, forearm sleeves that the quarterbacks have at the plays. We can have the brachial plexus on there when we do our EMGs. So, but the money's up here. C5, C6, upper trunk of the brachial plexus. So that's where the burners and stingers are happening. Imaging-wise, workup. So anything that lasts more than a few seconds really should be worked up. I mean, X-rays, cervical spine MRI, looking at central or particularly foraminal stenosis. If there's any concern regarding possible fracture, you may consider a CT scan. If there's persistent neurologic abnormality, consider obtaining an EMG or a nerve test. The caveat to the EMG is that it often takes about 3 weeks to fully mature the findings for the EMG, and so if you do it too soon, you may miss some things. So you really need to wait that 3 weeks before you're going to be doing it. So it's not all that useful as far as an initial kind of screening examination or utilizing it from a return to play standpoint either. Return to play, once again, asymptomatic, full range of motion, normal neurologic examination. In regards to the Dr. Cantu's more recent guidelines from 2013, most of the authors will agree with this. 1 or 2 episodes here lasting less than 24 hours is not a contraindication returning to play. And even 3 or more, or even those with prolonged symptoms or residual symptoms, that puts you into the relative contraindication category, which typically in sports medicine, relative contraindication means unless there's severe extenuating circumstances, then it's okay to return. Spear tackler spine. This is a trifecta of things. The three issues here are that you have a loss of cervical lordosis, a very straight neck, you have some degenerative changes, and then the third issue is that you have a history of using your head as a battering ram and spear tackling. So the 3 of those put together is an absolute contraindication to return to play for contact sports, because you're just asking for trouble. If you have somebody who's continually using their head as a battering ram, has a straight neck like that, as well as some degenerative changes already on top of that. So there's been a huge youth movement in youth football, huge education movement in youth football, talking about heads-up football, see what you can tackle, heads-up tackling. So you get the head up, off to the side. Hopefully you're not getting a burner out of it, but at least you're not using your head as a battering ram. Helmets, the advent of the safety, or the safer helmets as time has gone on, been a little bit of a double-edged sword. Obviously we're trying to protect the skull and the brain, but now we've allowed some of these ball players an extra weapon, which are being used as a battering ram with spear tackling and such. Disc herniations don't occur all that often in the contact sports, but they certainly can. Here we have a C5-6 disc herniation, off to the left side there. If you recall, the axial images of the MRI directions are backwards, so that's towards the left. These guys will present, as Dr. Villavicencio was mentioning this morning, pain down the arm, possibly numbness, weakness, reflex changes. The treatment is going to be your typical NSAIDs, PT, time, more PT, possibly an injection, and if they're failing the conservative management, or if they have significant neurologic findings or any progressive neurologic findings, that's when they need to consider surgical intervention for it. So the only caveat here with the disc herniation as far as the return to play guidelines really focuses on asymptomatic, because these are the injuries that linger. They take months and they take a long time to get better. Typically routine repeat imaging not recommended or necessary. Usually people will get better before their images get better, but you can consider repeating the imaging if they're not progressing in a typical fashion, or if they're not, or if their symptoms are changing in any way. Spine fractures. The treatment of spinal fractures, a little bit obviously beyond the scope of this talk. Suffice it to say that vast majority of spinal fractures, once they're adequately healed and treated, assuming that there's nothing abnormal about the follow-up imaging or any funny angles or whatnot, usually most of these are not a contraindication as far as returning to play. Here we have a C7 spinous process fracture. There's no instability issues here, so this will heal up just fine. On the picture on the right, there is a C2 odontoid fracture. We're going to have a lively discussion later with Drs. Rajpal and Nelson about the surgical or non-surgical treatment of this and in the elderly, different patient population. But just a reminder, we're in Boulder County, so that 78-year-old woman with this C2 fracture, she's probably thinking about when she can get back to roller derby or when she's going skydiving. So, everybody's an athlete, so you got to know your patients. So, once again, asymptomatic, full range of motion, normal neurological examination. You guys getting sick of hearing that, I know, so hang with me just a few more times. You got to really have the healed fracture. Your follow-up imaging here is obviously very important. You're not seeing any instability. Surgery, we'll talk about in a little bit. With some of the different issues there. Stenosis, this is a little bit of a grayer area. There's not a lot discussed in the literature as far as return to play with the contact sports with stenosis, which is interesting because there's certainly a fair number of football players with certain nationalities that have some congenital narrowing, congenital stenosis, that sort of thing. In this case, obviously, it's kind of a no-brainer. I mean, this guy's got severe stenosis. He's got some, I don't know if you can see it, but some intrinsic cord changes there. So he needs surgery, so he's out. Historically, Torg and Pavlov came up with a ratio, which is an X-ray evaluation looking at the diameter of the canal, which is our A here, and then dividing that by the diameter of the vertebral body, which is B. And seeing that a number less than 0.8 was a predictive indicator of cervical spinal stenosis. Follow-up studies and evaluations, and with the advent of MRI and the utilization of MRI, this isn't really used anymore all that frequently as far as either a screening process and certainly not a return to play guideline at all. But you should know about it just from a historical standpoint. What we're using now is really talking about the functional reserve. So this is taking the diameter of the spinal canal, looking at how much of the spinal fluid that's surrounding the cord, and that's what the functional reserve is. So that's your cushion of protection per se, okay? And you can see here on a couple of pictures, the one in the middle there, there's a broad-based disc bulge, some leftward foraminal narrowing. The cord's starting to become a little bit flattened, so you're losing that cushion of protection, or you're losing that functional reserve. Same thing on the right there. It's getting a little bit narrowed, getting a little bit concerned. So stenosis, here again is our trifecta of return to play guidelines. It's really dependent on the severity of stenosis. You know, particularly if this is a fixed issue and it's not secondary to a disc protrusion or a disc bulge. You know, the levels out there are kind of thrown around. I mean, typically you'll think about a normal spinal cord diameter, or excuse me, spinal canal diameter as being about 14 millimeters or greater, but that depends on the level. So some people will say, you know, in between 11 to 13 millimeters puts you in the relative contraindication. Certainly less than 10 millimeters, you really shouldn't be bashing your head around out there, because that's going to be a contraindication. Post-operative, I'll tell you what the guidelines will discuss, then I'll let my neurosurgical colleagues correct me and tell me what the real world looks like. But Maroon in 2013 produced this study. I have a little bit of data here, so hang with me for a couple of slides here. Excuse me. So he took 15 pro contact sport athletes that he performed a single level fusion on, and 13 of those returned to their respective professional sport. One of them had a reoperation secondary to adjacent segment disease, so his data suggested 1 of 15 gets adjacent segment disease. 2 of those 15 had cord signal changes, which he indicated he felt, or I'm sorry, 1 of those returned to play. And so he opined that cord signal change may not necessarily preclude a return to play. Generally speaking, most authors, most experts out there will say that those that have cord signal changes should not return to play with in a contact sport. He used the normal exam, full motion, and a solid fusion as his return to play guideline after a single level anterior fusion. So we'll just be redundant. We're going to add asymptomatic to that. We're also going to include the solid fusion, obviously. Gotta wait till that's safely healed. Typical guidelines out there will say a single level ACDF, likely 2 level. A single level is okay to return to play at second level, puts you in the relative contraindication, but definitely not an absolute contraindication. Any type of foraminotomy, as it was discussed before, is fine. There's you know, even a foraminotomy with a laminotomy, there's minimal resection. It's not causing any instability. Single level fusion posteriorly, little bit of a gray area, a little bit more of a debate, but most authors will say that a single level posterior fusion is probably okay to return to play. So general rule of thumb, 2 levels anteriorly, 1 level posteriorly. This guy, yeah, no. He's got to take up back in. Transient quadriplegia. So transient, obviously temporary. It's not a permanent injury, but it is a spinal cord injury. So you have quad, which is your 4, your plegia is complete, or paresis is partial. Temporary is minutes to hours, prolonged is greater than 36 hours. Cervical cord neuropraxia is another word for it. These are the athletes that develop paralysis, typically after tackling. They've developed a paralysis, they recover days, usually less than that, maybe hours to days, and typically have normal imaging. So then there's always the question of, can they return to play? And Dr. Cantu's guidelines, most of the guidelines out there, after the first episode of transient quadriplegia, it is okay to return to play in a contact sport. Although that's a spinal cord injury, it is a temporary one. Although I ask each and every one of you, if that was, you know, if you're put in that position and you're making that decision, how are you advising the athlete and the parents? And then take it one step further, if that's your family member, what are your recommendations along those lines? Actually, as we'll see when I review the entire guidelines, the second episode of transient quadripresis, according to Dr. Cantu in 2013 guidelines, he's still allowing those folks to return to contact sports. So lightning strikes twice. You know, everybody's touting it as a miracle, I don't know what kind of fire we're playing with there. So Torg looked at the data, and he combed the data, and he looked at it, and he said, okay, there's 6 out of 10,000 transient paresthesias in all 4 limbs, which is sensory only. 1.3 develop with transient quadriplegia, including the motor. 117, different look at the data here, different study. 117 complete spinal cord injuries, so those with the injury, permanent spinal cord injuries. None of them had a prior episode of transient quadriparesis. On the flip side, looked at 110 contact sport athletes with transient quadriplegia. 57% of those returned to contact sports. Amazingly, 56% of those that returned to contact sports had a second episode. None of them were permanent. So Torg basically said this is a separate entity, transient quadriparesis and spinal cord injury. So running out of time here, so I'm going to plow through a few of these. So return to play. Okay, if it's after 1 episode, debatable. Guidelines state so, but I do have a hard time with that. And then what about if it's mild stenosis, mild degenerative changes, or a second episode? If there's a spinal cord injury itself, that's a contraindication to return to play. So permanent spinal cord injury is a contraindication, except if you play quad rugby, which is quite the contact sport post spinal cord injury. So return to play, it's controversial, it's expert opinions. These are guidelines. There's multiple pressures. I know you don't know how many high school athletes are on the verge of Division I scholarship. If only you'd let them return to play. So sometimes you got to make the tough decisions, right? So here's a brief run through the guidelines. You guys can look through these afterwards. Most fractures are fine. Congenital changes with clipophile, as long as it doesn't involve C0, C1. Spina bifida occulta, a couple of stingers, 1 level anterior fusion, 1 episode of transient quadriparesis. Relative contraindications, which, like I said, typically mean fine, because if somebody doesn't see the absolute in front of it, that's what they're going off of. 3 or more stingers. Interesting how they put the prolonged symptomatic burner and the prolonged transient quadriparesis kind of in the same category here. So absolute contraindication, C1-2 fusion, multiple, more than 2 episodes of transient quadriparesis, or anybody that's still symptomatic, laminectomy, 3-level fusion, anteriorly or 2+ posteriorly, and then some of the weirder ones there on the bottom right there, the Arnold Chiari, some of the cervical spine abnormalities in AS and NRA. So, quickly with the questions. First of all, 17-year-old high school football player unable to move his arms or legs after making a tackle. It's complete neurologic recovery after a couple of hours. You diagnose with transient quadriplegia. On follow-up, his normal neuro exam, normal imaging, can he return to play in contact sports? A, yes, B, no. I got the good news. All right. So let's see. There we go. Yes. According to the guidelines, yes. I'll let you make your own judgments regarding how you would manage it. So next, let's see. Next slide. So if it happens the following season, second episode, 18-year-old now, same episode, or same issue. He returns function after transiently being paralyzed. Once again, normal imaging. You let him return. A, yes, B, no.
Huh?
All right, it's coming down a little bit. Technically, according to CAM 2's guidelines, you'd be, you can justify it from that standpoint. I would say no. I can't go there. This is just a poll question. I was just curious. I do or will allow my kids to play tackle football. Interesting. So we'll see. Concussions have taken all the limelight, but the cervical spine, is creeping up there as far as a potential issue. So we got 2 more questions. This is the academic question. So which of the following is not a contraindication? So I screwed myself up when I was answering this. I actually answered it wrong, so I got corrected. So I won't blame you. So which is okay to return to play? Yeah, that's correct. So healed C2 fracture. So C1-2 fusion, usually a single fusion is okay except if it's high. So healed C2 fracture is okay to return. The others are contraindications. All right, so this one, last question is really tough. Why are you here today? College football sucks. I know why I'm here. A little extra sleep. All right, let's see what we got. All right, thanks guys. Be great.